All right, let's dive in. Today, we're going to pull back the curtain on chronic lymphocytic leukemia, or CLL. It's one of the most common types of leukemia out there, but it can be pretty complex. We're going to start with a story, a scenario that might seem surprisingly normal. So, picture this. A 65-year-old walks into their doctor's office for a totally routine physical. They feel great, nothing's wrong. And this is a really crucial point because for about a quarter of all people with CLL, this is exactly how their story begins, with zero symptoms. It's discovered completely by accident. But then the blood work comes back from the lab, and something's off. The numbers aren't right. All of a sudden, what was just a normal checkup turns into a medical mystery. And that unexpected result? Well, that's our doorway into the world of CLL. So what is really happening here? To get what's going on, we have to zoom way, way in. We're talking about the microscopic level, where we meet the body's own rogue cells. So, what is CLL exactly? Well, officially, it's a cancer where you get this slow, steady buildup of abnormal B cells. Now, your B cells are a key part of your immune system. But in CLL, one of these little guys basically goes rogue. It starts making endless copies of itself. And those clones start to pile up everywhere, in your blood, your bone marrow, your organs. You can almost think of them as zombie cells. Seriously, see, a normal healthy cell has a built-in self-destruct program. It's called apoptosis. It knows when its time is up. But these cancerous B cells? Nope. They've totally forgotten how to die. They just keep cloning themselves and piling up. And who does this usually happen to? Well, you can see here, CLL is overwhelmingly a disease that affects older folks. The peak age for diagnosis is somewhere between 60 and 80 years old. It's pretty rare in people under 50, and you just don't see it in kids. Okay, so you've got this microscopic invasion of zombie cells happening on the inside. But what does that actually feel like? How do all these tiny problems show up in the real world? Well, as we said, many people feel nothing at first, but the most common physical sign is swollen lymph nodes that don't hurt. As these leukemic cells start to crowd out the bone marrow, they push out the good guys, the cells that make red blood cells and platelets. That's why people might feel totally wiped out from anemia or notice their bruising super easily. Some people also get what doctors call B symptoms, things like unexplained fevers, drenching night sweats, and losing weight without trying. Now, hearing all that might sound pretty scary, but here's some really important context. The 5-year survival rate is over 81%. What that tells us is that for a whole lot of people, CLL is a chronic, slow-moving disease. It's something that can often be managed for a very, very long time. All right, so a doctor sees some weird numbers on a blood test. How do they actually confirm it's CLL? Well, it all starts with taking a closer look, a much closer look, under the microscope. And this is pretty cool. The very first clue is often right here in what's called a blood smear. These CLL cells are super fragile, so when a lab tech spreads them on a glass slide, they can literally break apart, creating these, well, smudge cells. Seeing these is a massive telltale sign for a pathologist. But to be 100% sure, you have to go right to the source. Let's think of the bone marrow as the factory that produces all of your blood cells. A biopsy of this factory tells doctors not just what's being made, but it also shows them just how much of the factory floor has been taken over by these rogue cells. And you know what's really interesting? Even the pattern of how these cells are spread out matters a lot. If the cancer cells are clumped together in these neat little clusters, that's the nodular pattern you see on the left, that usually means a slower growing disease, a better prognosis. But if they're just everywhere in what's called a diffuse pattern, like on the right, that can point to a more aggressive disease down the road. And we can get even more precise by diving straight into the cell's DNA. See, certain genetic quirks can tell us a ton about the prognosis. For example, if a little piece of chromosome 13 is missing, that's called a deletion of 13q, that's actually linked to the best possible outcome. But other changes, like losing a piece of chromosome 17, tell doctors to expect a more challenging fight. These genetic clues are absolutely vital. Okay, the diagnosis is in. We have an idea of the prognosis. Now what? It's time to map out a plan of action, and that starts with staging the disease to figure out just how advanced it is, and then deciding what to do about it. A really common way to do this is with something called the RAI classification. It's basically a step-by-step system. It starts at stage 0, where all you have is a high lymphocyte count in the blood. As the disease progresses, you might see swollen lymph nodes, then maybe an enlarged spleen or liver. And in the later stages, it starts messing with your red blood cells and platelets. Now, this next part might just be the most surprising thing about the entire CLL story. For people in those early stages, the ones without any real symptoms, the most common recommendation from their doctor is to, well, do nothing at all. Yup, this is literally called the watch and wait approach. And it makes a lot of sense when you think about it. Since the treatments are all about controlling symptoms, they're not a cure, it doesn't make sense to start potentially toxic therapies until they're actually needed. So you monitor the patient closely, but you don't actively treat. So when do you flip the switch from watching to acting? Well, treatment usually kicks in when the disease really starts to cause trouble. Things like clear signs the bone marrow is failing, or if the spleen gets so big it becomes a problem. Same for the lymph nodes. Or if those really debilitating B symptoms, the fever, night sweats, and weight loss, finally show up. And when it is time for treatment, the options today are just night and day compared to what they used to be. We've moved from the sort of sledgehammer approach of old school chemotherapy to these incredibly specific targeted therapies. We're talking about drugs like BTK inhibitors and BCL2 inhibitors. They're designed to go after the cancer cell's specific weak spots, which means they're often way more effective with fewer side effects. And that really brings us to the big picture here. The whole landscape for CLL has been completely transformed. What was once a disease treated with harsh chemo is now often a chronic condition that people can live with and manage for decades, sometimes just by taking a pill. So as these incredible targeted therapies keep getting better and better, what does the future of living with chronic lymphocytic leukemia look like? Well, it's looking brighter than it ever has before.